objectives and some discussion prompts we thought might be helpful to frame the conversation. And then we'll start accepting comments. So if you can move to the next slide. The purpose of the evaluation was really to develop a system for establishing and maintaining rates that are sufficient to sustain main providers and ensure main care members have access to high quality services. It's also to evaluate main care's rates and rate setting system to develop a plan for the creation of a comprehensive, streamlined, and coherent system moving forward. Within the timeline of how the project is progressing, we did the provider listening sessions in October, we did member listening sessions in November, and now we're here in the second session of provider listening sessions. We released the cataloging and benchmarking report in November, and what we're working on now are the interim findings in the final report. And you can see on the slide the information that's intended to be included in the interim findings, such as recommendations to simplify and streamline the methodologies, a process for conducting ongoing rate reviews and rebasing, and a priority list for recommending short and longer term rate reviews. Go ahead and move to the next slide. So our role in the meeting today is to ensure that participants keep their comments within the announced time frame. This isn't a huge meeting, it's a little larger than our other ones, so I'm not going to impose a hard 5-minute rule, but I do ask that everyone please respect everyone in the meeting and give people an opportunity to talk. If you have gone and you still have more to say and we have more time, I'll open it up again for more comments, but I just ask that we all respect each other in this meeting and give people time to speak. Also, please just ensure your comments pertain to the topic today, and then of course, we're recording the meeting. Your role is to introduce yourself, your organization, and the services you provide. That's to help us associate the right comments to the right sections. If someone says something that you agree with, you can just say you agree with them rather than repeat all of their points. And just like I said, respect the time limits and respect each other in this meeting is all that we ask. Go ahead and move to the next. The purpose of today's meeting is really to get your feedback on additional points that you suggest that we consider regarding the rate comparisons, and then to let us know about the sufficiency of your current rates and any issues related to the rates and their impact on access or sustainability. So we have a couple of sample discussion prompts. This is really to help if you were wondering what we're really looking for and ways that you can provide feedback on areas that we already know are areas we would like provider input. Are there assumptions or costs that are critical to consider that may be unique to Maine that wouldn't be reflected in another state's rate to help provide context to that comparison? Are there differences in payment methodologies, services that may explain some of the differences in certain rates, though it may not be evident by the fee schedule or service descriptions alone? And are there services where current rates contribute to access or quality issues? And then do these issues impact other parts of the service system? So these are just some ideas of how you could give us feedback. But we will go ahead now, and if you would like to speak, please raise your hand. If you can't find the hand signal, which again, if you click on the blue participants tab, and it will bring up that tab, and there should be a little hand next to a megaphone. If you can't find the hand to press, you can chat to us in the chat box, and Jillian can unmute you that way as well.
Okay, I've got our first hand, Julie.
Good morning. Can you hear me?
Yes.
Okay. So my name is Julie Schermer. I represent NASW Maine, National Association of Social Workers. As chair of their policy committee and vice president of their board. And my experience and expertise is mostly around outpatient mental health. So when I looked at the overall studies that you did and the overall comparisons, outpatient mental health is around 88% comparison rate to the other states, which is probably the worst of all of your overall comparisons, including substance use, which is 92%. Adult-based mental health 91, and children's services looks the best. And Maine being such a rural state, what we're concerned about is the outpatient, the accessibility and availability of outpatient mental health services, particularly in the rural areas. Mental health is 4th highest ranking concern for rural health America. And a lot of it has to do with accessibility. And in Maine, the accessibility is also an issue. Social work, psychologists, LCDCs are not that frequent in the rural parts of Maine. And this is from my experience of over 40 years working in Portland, which is not rural, in a primary health clinic, producing, I was a clinician and an educator for the Tufts Maine Medical Center program and for family medicine residents at Maine Medical Center. So we had people coming from all parts of the state and then trying to find services for them outside. Certainly it was mostly in the Portland area, but the hardest people to find care for were people in the rural areas. When you look at your outpatient rates for, say, private clinicians, they're some of the worst rates possible. And of course, representing NASW, I looked at the social work rates. So those comparison rates were, 74% comparison to the Medicaid rate of only one state, and that was Vermont. There were no other, you didn't have any other comparisons for that. And there were no comparisons for commercial. So those are pretty low, and I think those contribute to folks with Maine Care who need outpatient mental health services. I've been in numerous supervision groups with people who have outpatient practices, who are outpatient independent clinicians. Many of them don't take Maine Care. And whether that's because of rates, whether that's because of complexity, whether that's for people showing up for appointments, there's lots of different reasons why. But in the rural parts of our state, those independent, it's key to have people that are close to people's homes, which the independent clinicians are more likely to be than our community health. Our community mental health agencies. So my push is to really help those independent providers and the agencies have higher rates for adult outpatient, given the complexity of people and the multiple barriers, particularly in the rural areas, that affect folks' ability to get treatment. So I think that's all. I could give you statistics about, why it's so important, but I don't think that that's what you want to hear today. Thank you.
Thank you, Julie. Next up, I have Dale Hamilton.
Good morning. This is Dale Hamilton, Executive Director of Community Health and Counseling Services. we provide a variety of services, including outpatients. I just wanted to comment because some people may not have been involved in the stakeholder meeting on Friday with the residential, and you made an important distinction that was helpful for me to hear in terms of the process that you're using, what your role is in terms of getting to the rates. That you're not recommending a rate, you are recommending a methodology for the rates, and I thought that was an important part. And with that comment, I just wanted to relay that the comparison. I just have questions in terms of then if your role isn't to recommend a rate and it's really about the methodology, how do the selection of 5 states without providing the methodology behind those rates play into your role? And with that, just wondering if there'll be an opportunity for stakeholders to see the methodology behind some of the rates. I think Vermont, for example, there's certainly the impact of value-based purchasing, and I know that that's been a discussion in terms of looking at that. And I just think it would be, stakeholders could provide more meaningful feedback if we were able to address the parts that you'll be ultimately looking at, because a comparison of rates, if it's about methodology and you're just looking at a number, it really doesn't play into that role. So I just wanted to reflect on that.
Thank you, Dale. And just to add to that, for everyone who wasn't in the residential meeting, where there weren't a lot of ability to benchmark some of the residential settings. And so one of the things I think it is important to understand is that really what the comparison percentage is saying is that this is how you compare among your neighbors. This is what everyone else is paying for this code in your geographic proximity, which doesn't necessarily mean that that's the rate that it should be. It means that this is how you compare to everyone around you, essentially. And so what it is doing, though, is sort of orients you to where your rate is within the field of states and Medicare. There were the comparison points. But it's to help provide that information so that when we're looking at making recommendations on back to the project objective, which was to create a streamlined and effective method for doing rate reviews and rate setting going forward, it helps to orient everybody to where all of your rates sit within that spectrum. So thank you for bringing that up. I agree. I think that's an important point as well.
Based on that, could I just make one quick comment?
Sure.
So just with that, I think that's where not knowing, I believe you've mentioned that those are the rates that you pulled that are paid by the Medicaid portion, and that you've obtained that through the public documents. But one of the things that would be really important is to understand, are there, like if there's a value-based purchasing component where the rate is a base rate and then the provider earns X number of dollars for performance, that rate would be higher than what's published. And when you do a head-to-head comparison, that would be the rate that would be an apples-to-apples comparison. So I just knowing what goes into the rates for all those other comparative states would be important to really get an understanding of what we're truly, where our baseline is compared to those other states.
Julia, if I may, just to clarify, so the intention was, to the best of Myers and Stauffer ability, given again limitations on time, that the intention was to try to pick out comparisons where, from what they could tell based on publicly available data, it seemed it was comparable. So so if it's the same code and the code is supposed to have the same definition and it doesn't say anything about, for example, a performance-based payment on top of that, then that's what we had to go off from. So, if you look at reports, there's a number of instances where Myers and Stauffer has indicated there is also a performance-based payment for this kind of service, but we just recognize that in the absence of in-depth research or interviews with comparison states, there is likely information on payment methodology that is not easily publicly available that we're not sure about. Julia, is that fair?
Yeah, that is a really good point. And like I said, that's why if you look at some of the more, what I'll say, social support healthcare systems, there aren't comparators, or there are not as many comparators. And that was because we did not want to make a bad comparison. So where it was obvious that it didn't match, or that the codes varied too much to be comparators, we did not include them. And we tried to only match ones where it made sense to match that, but also not having been, worked in state myself for many years, we don't post everything on the website. So there's a lot of things that you can't know just by looking at that. So I would say that we did our best to make sure that we were only comparing like services. And but if you have identified any where you feel like it's not a good comparison, and for certain reasons, and you want to send those to us, that would be feedback that would be very helpful as well.
Okay, thank you. Next up, I have Pete Plummer.
Hi, thank you very much for this opportunity. I appreciate it. I'm the COO from Woodford's Family Services, for those who were listening. Can you hear me? I guess my first question.
Yes, we can.
Okay, great, thanks. We provide an array of services that are on the table of contents today, and I'm going to comment on two, and maybe I'll comment on a couple more later, but the two that I want to comment on are Section 28 in-home support services for children. Just first of all, on your spreadsheet, you're missing one important rate. It's H2021 HK. You have the group rate, but the one-to-one rate's not in there. Just so you can add it in, it's really the rate for the specialized one-to-one. I'm sure I know there's lots of volume in that rate, and it's just missing from the spreadsheet. This rate, when it's really, it's also going to be going to EVV effective, 3 weeks from now, January 1, 2021. There's been no additional reimbursements for this rate for that additional unfunded mandate. I know it's coming from the federal government, but it's a lot of extra time, effort, and work and setup, and it's something that I hope that's looked at when this rate is re-looked at or reestablished. A second thought is this rate is really for a service that's provided mainly at night in homes, and it's a part-time job, and there's long waiting lists for a lot of these kids due to any number of reasons. And one of the things that I hope that you look at when you look at the rates are the waiting lists for these services, and part of it is with a rate, of course, that drives what we can pay the staff, and it's hard to find staff, to work nights and weekends as it is. It's a part-time job for a lot of people, and so if you can take that into account when you look at the salaries that are offered to these people, and that's, it's very, very difficult, and the other thing is the BCBA rate that's in Section 28. It's the G9007, the $16.60. That's hard to come through. I know when they came up with that rate, I think it comes from a Burns study, and the activity expectation of the BCBAs was just horrendously high, which drives that rate down. These are master level positions that have to do a lot of work that's non-billable, but it just doesn't come out right. So hopefully that will work its way through. But it's the long waiting list, and the rate's not high enough as it is to get that waiting list down so we can hire staff to treat these kids in the home, which is really the best place for them to be treated. The other thing that I want to talk about real quick is Section 65 day treatments, and really specifically for all kids, but I'm going to focus on a specific population. The 3 to 5 year olds in the preschools. We have 3 preschools throughout the state of Maine that we bill Section 65 day treatment for, and that's all the revenue that we receive. I know that there's other studies going on in the state in different areas to look at this, but I don't know how those are all going to intersect. So I'm just going to talk about this one service. When you look at the model, these are preschool services that are run by Child Development Services concurrently, or some educational system, for the referrals. And the money that we receive is all inclusive for the 3 to 5 year old population. And I'm hoping that when you look at rates, you look at other funding opportunities. The K through 12 programs receive extra funding from DOE, but CDS provides no funding for the kids who get treatment through day treatment. They provide funding if you don't qualify through day treatment, but I hope you look at the total funding. When I look at the rates that we're using the comparison, there is a wide variance of rates in other states. And without knowing if there's other funding that goes into some of those rates, by looking at that one service alone, it's really, really tough. Another thing on that's not in place now, but there's a process that wants to limit the treatment of gay treatment to what an education plan states, not what a treatment plan states. And this is really a medical service, not an educational service. And so I just ask that you're open to understanding the differences between the treatment and the education, and not limiting the treatment based upon what an education plan states. So those are my couple of thoughts for those 2 programs, and I'm not really prepped yet to comment on others. If I do, I may raise my hand again. But thank you so much for the opportunity.
Thank you, Pete. Next up, I've got Margaret.
Hi, this is Margaret Longsworth. I'm the Director of Mental Health and Clinical Services at OHI. We provide Section 17 skills development. We have also provided a couple of other Section 17 services that we have stopped providing because of financial losses. One of the things that I wanted to point out was that when the rate was originally developed for skills development and DLS, I realize we're not talking about DLS right now, it assumed that the assessment and the treatment plan would be done by a case manager. When these services were first developed, you had to have case management services in order to get them. And then as soon as that was rolled out, the system realized, oh, we've just violated our own rights of recipients of mental health services. The DLS and skills development were then broken off as standalone services, but the rate was never adjusted to compensate for the additional time and expense that was associated with this, creating assessments and treatment plans. I would reiterate the comments that I made on Friday about the comparison states minimum wage and the impact that has on the comparison codes. I'd also, even though we don't provide Section 65 medication management, I want to just make a comment about the possibility or the suggestion of developing a separate code or an add-on code for those medication managers who support progressive treatment plans. OHI provides a lot of residential services, mental health PNMI, Appendix E, and some of the really challenging to serve folks who have had PTPs have actually been able to experience success. And, you know, that certainly improves the quality of their lives and saves the system a whole lot of money. But trying to find somebody who will take on a PTP is very challenging. Thankfully, in Bangor, we have Sandra St. Gervain. I don't know when she might retire, but when she does, it's going to be very bad. And I know that when we're taking people who are referred from other parts of the state, I hear nobody in, you know, X, Y, or Z area is willing to take on a PTP. So I would just encourage that examination as we go through this process. Thank you.
Thank you, Margaret. Next up, I have Lisa Career. Okay, it looks like we've got your comment in the chat instead here. I'm not seeing anything else in the chat or any additional new raised hands. Okay, here's one. Mallory Shaughnessy.
Hi, thank you for the opportunity. This is Mallory Shaughnessy with the Alliance for Addiction and Mental Health Services. And I want to reiterate a couple of comments made from Monday because they pertain to these services as well. In sort of backing up to the very general overarching sheet that talks about summary of rate bases and updates by section, I noticed that section 65 behavioral health services, they mention basis is rate studies and other, and that last major update was 2020. And I just wanted to note that there were some very minor adjustments of like 2% to rates, but that is not a major update. And most of those rates did not have major updates for, you know, a decade or more. So I just really wanted to verify that or to clarify that or concerns about that being listed that way in this overall view. The other concern I would share too is when we look at the procedure description at the very beginning and we talk about the comparison percentages and defining outliers, and outliers that are high are defined and, you know, flagged. If they're high, they're greater than 120% of the comparison rate, but they're not flagged as low until they're below 40% of the comparison rate. And that combination just on the surface doesn't make sense to me, and I don't know what the reasoning was behind that. You would think if it's 120 as a high outlier, then 80% would be the low outlier in that sense. So just flagging that as a concern overall for all of these rates. And then just to reiterate the comment that was made earlier, that when we look at the behavioral health outpatient services, that many of them are much lower. When you look overall at the sort of key points, we see that you know, many are, you know, one is even actually an outlier of below the 40% in skills development services, but then overall the spending is only 83% of what it would be for it was like, no, sorry, that's the community base, that's later today. But basically the outpatient rates are, when you look through here, many of them are much lower than the other comparisons. Outpatient mental health age services, 88.1% of the comparison rate. So much lower, with some ranging from 57% up to 1 or 2 that are above 100%. Most are below. So when we're talking about just the comparison, we are showing kind of low, and I think that shows, as somebody else referenced as well, that we have wait lists for many of these services, and some services that we don't carry wait lists for, such as med management and others, it's still, there may not be a technical wait list, but it's 6 to 8 months sometimes to get into an appointment. So therefore a wait list, which shows lack of access and which is directly related to the rates. And one other point too is if we look just at the last 4 years, 5 years, we see, I know you want to hear about like access issues, and we see a number of agencies that have closed services, a number of agencies that have cut back on services. There's very few agencies currently providing medication management for those on main care. There's very few providing a number of different services under main care because the rates are too low to sustain provider involvement. And I think that those are key pieces that have to be reflected. And I would hope that there would be some kind of a review of how many services and which services have been cut back over the last few years. So sort of on a higher level, I'll be submitting more specific comments, but I just wanted to really get those higher level kind of reflections on record. Thank you.
Thank you, Mallory. Let's see. Next up, I have Pete Plummer again.
Yes, thank you. Just I'll be quick this time. And it's really to follow up on Section 65 medication management services. Two things there. One, on your rate sheet, you have a rate of $80.20, and that's higher than the rate in Chapter 3, Section 65 for medication management for the children. And there's actually two rates, one for $74.59 and one for $65.26 for the same service. And so, my first request is to get the, reconcile the rate. My second request is there's two rates in medication management. And we're one of those programs that struggled with one of our programs, a children's program, and we just couldn't fiscally maintain it anymore. And one of the reasons being is we had to charge a lower rate. We had a physician assistant, very experienced physician assistant that did a wonderful job, but we wish we could have charged the same rate as the MD, the psychiatrist. There's two separate rates, and a high percentage of the services are done by nurse practitioners or physician assistants, and so if we could have equitability in the rate, it might help with the program and not have two separate rates, because it ends up underfunding the and there's lots of no-shows in this business and call-outs, and people, that's because they need lots of help, and there are undocumented waiting lists, but if you could make the rates the same, and that would be great. So thank you.
Thank you, Pete. Let's see, I've got a few more comments in the chat, which we will be recording. But I don't see any new raised hands or any requests to speak in the chat.
Okay, thank you, everyone. I want to open it up one more time here. If anybody would like to make a comment or like to make a second comment, and if you have raised your hand and you have not put it down, we can't tell the difference if this is a new request or your old request, so if you put your hand down, that helps us to figure out if you want to speak again or if you're done speaking. And also, don't hesitate to chat to us, like I said in the chat box, if you can't find the hand raising signal.
Okay, I have Mallory Schwartz.
Hi, thank you. I will be quick on this second comment, but just looking again at the prompts and on that last one, access or quality issues. And I just want to make note that Maine is trying to move towards evidence-based practices and evidence-based services. And we do have some services that are evidence-based, but when they're not fully funded, and if you try to do them to like fidelities to models, or if you try to do, as somebody referenced earlier, med management, and you're working with people that have PTPs and other things, there are so many unbillable services that have to be included to be collateral contacts and other pieces to truly provide the service that's going to best meet the needs of somebody struggling with mental illness, to really find, do the quality of service. But there's so many unbillable parts that states, like when you look at, and Dale mentioned, when you look at Vermont with their per member per month services, they are able to cover a lot of those within rates in a different way. So I just wanted to, really highlight that when we get to quality, having rates that are too low or that don't account for those collateral pieces reduces the quality tremendously.
Thank you, Mallory. Next up, I have Ken Olson.
Hi, this is Ken Olson from Kids Piece. I appreciate the effort to try to gather information from other states, but I do have a question as to whether, in addition to looking at the rates in those states, whether your analysis also includes any issues that those states may have around access. A lower rate in another state where they have significant access problems would have a different meaning than a lower rate in another state where those access problems didn't exist. So that's just a point of curiosity for me. Thank you.
Hi, Ken. No, that's a good point. And while we look at how mental health or some of the other services are operating in the states, we don't have the detail level. We didn't do interviews in all of those other states. But I will say that one of, if you look at the executive summary, we do talk some about limitations and recognizing that while we're presenting the rate in the other state, it's really, again, just for comparison, and we're not suggesting or recommending that that be the rate that you adopt. You have a methodology to set the rates for your individual services, and it's really just to provide comparison. Purely, that is its function, to provide some context for where your rates sit within the array of those around you. Okay.
Sorry, Ken, if you wanted to respond, I think I muted you accidentally.
No, that's okay. Thank you for that. Thank you for your response.
Okay, next up I've got Mallory.
Not to belabor a point, but I think that Ken's point and some others that have been made are really critical when you're saying that we are looking at this simply to see where we sit amongst our peers states, but as a comparative, just sort of to see the lay of the land. But when the land is completely different in each state, it doesn't really give you that much clarity of information. And so I still have some concerns with this being sort of a baseline or a comparative that is going to be locked into this, in that we're still don't even know if we're comparing apples and oranges and orangutans. So I just, really want to put that out there again, that not having the depth of what's happening in these other states in comparison, when you consider all these other factors, really doesn't give us a good kind of apples to apples comparison.
Thank you, Mallory. I agree. Certainly there are limitations. And I think that's also why we've had both of these opportunities for providers to give comments, and why we included these on the discussion prompts, recognizing that there are things unique in each state. it wouldn't be reflected just in the rate or the service description or things that can be found in publicly available documents. So thank you all very much for giving us time actually to come and help provide some of that context. It's very helpful.
Julia, I would just also add that I think that one thing that I found helpful with this study is that it gives us an idea of areas where we should be asking questions and doing some more research as a state to figure out why is it that things look this way, and does that totally make sense, or is there an issue? And so the comparison certainly does not provide us with all the answers, but I think having an idea of where it makes sense to ask questions because it seems like something different is going on, and then ask questions to see whether or not that is justified is helpful information.
Okay, next I have Dale Hamilton.
Thank you again. Just a real quick, I just wanted to follow up on something that Margaret pointed out around medication management. And it's to your point in terms of the rate process methodology. We're already seeing a movement to include certain expectations in some of the services and contracts, including medication management. And there have been comments and suggesting that other parts of main care we may see other statements of requirements. And so the requirement to participate in a PTP plan is much more for a medication management provider, is more than just delivering the medication management service. So when you're comparing medication management service, what it is compared to another state, you're looking at it from a head-to-head of this is what's required. When you start layering on new expectations or requirements, that's above and beyond the comparison in terms of the rate. The reimbursement does not include all the aspects that are required around a PTP plan. And when a provider takes that on, there is a requirement. It's not just specific to that medication management service. It entails the person's overall services and monitoring, including sometimes housing. There's a lot to it. So I think it's important to understand that, and as the methodology, that you're talking about a base service. This service is this is what it looks like, so that as a state, we can distinguish when other things are being asked of providers to follow through with a particular service, that we know very clearly that that's an add-on that's being requested and should be funded in a different manner.
Thank you, Dale. Okay. I am not seeing any new hands or any requests to speak in the comments or the chat.
Okay, great. Well, thank you everyone so much for giving us your time this morning. We truly appreciate it. If you have any comments to think of after the fact, please don't hesitate to send them to us at the email. If you go to the last slide, Jillian, there is, I believe, the email on that. Yep, the rate setting eval at maine.gov. And thank you again. We really appreciate the time this morning, and I hope you have a good rest of your day.
Thank you, everyone.